Good day, dear freshmen. On behalf of the faculty of the Department of Preventive and Community Medicine, I wish to welcome all of you once again to the UERM College of Medicine. Today, I have been tasked to discuss the various concepts of wellness and disease. I will discuss in detail the natural history of disease, as well as the different levels of prevention. At the end of the session, the students shall be able to first explain the various epidemiologic models of disease causation, including the ecologic triad of communicable diseases, with emphasis on the agent-host environment variables in the context of the biopsychosocial approach to health. We will discuss the natural history of disease, including the differences in terminology when it comes to illness versus disease. We will differentiate the various levels of disease prevention, and lastly, we will cite specific strategies of disease prevention and control aligned with the triple burden of disease. So let us begin. If you look at the operational definition of health as defined by the World Health Organization, health is the highest level of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Disease refers to abnormalities of the structure and function of the body organs and systems. As freshman medical students, you learn about the human anatomy, the basic physiologic mechanisms of the human body. When you go to higher medicine, when you go to, let's say, sophomore year level, when we talk of pathology, we go into the systemic changes in the human body, in the human organ systems that bring about diseases. That's basically what we're also trying to learn and discover. Diseases are the named pathological entities that make up the medical model of ill health and which can be specifically identified and described by references to certain biological, chemical, or other evidence. For example, when we talk of diabetes mellitus, we do know that there is a problem with the alpha and the beta cells of the pancreas that ultimately result to insulin resistance or insulin insensitivity that bring about your uncontrolled hyperglycemia. When we talk of diabetes mellitus, across all nations, we do know that we define diabetes mellitus when sugar levels exceed 7. So these are just some of the basic diseases that we learn about. And there is what we call your International Classification of Diseases, or your ICD-10, which includes the myriad of metabolic disorders, including mental health disorders, that define what diseases are from a global perspective. Now, diseases are seen as abstract things or independent entities, which have specific properties and a recurring identity in whichever setting they appear. Therefore, diseases are assumed to be universal in form as well as in their progress and content. In contrast, when we talk of illness, this refers to the subjective response of the patient to being unwell. This will encompass how a person and those people around that person, how they will perceive the origin and the significance of this event. It also looks into how medical conditions can potentially affect the behavior or the interactions or the relationship of a patient and the steps the person would take to remedy the situation. For example, when we talk of HIV, HIV is a retroviral infection that tends to affect the immune system of humans. When a person becomes infected with HIV, it doesn't automatically mean that this patient has already developed full-blown acquired immune deficiency syndrome. Rather, this patient can still take action to address the presence of the retrovirus in his or her body. For example, this patient can take your antiretroviral therapy to ensure that the CD4 count and will not go down significantly, and that viral suppression would be achieved. But once a person develops HIV, this will also impact on the way that person will interact with his or her family members. So, for example, if you are a PLHIV or a person living with HIV, you might be more cautious now when you engage in sexual activity with your significant other. And this can cause depression in the person with HIV, and there could be different coping mechanisms among the various family members of this person living with HIV. That is what we refer to as your illness. The impact of illness on the patient, as well as on the patient's family members, will reflect what we refer to in family medicine as the trajectory of illness. Now, illness includes not only the experience of the patient with the ill health, but the meaning he or she gives to that experience. Illness, therefore, is the patient's perspective on his or her poor health, a perspective which is very different from that of the disease models. Illness depends on a myriad of factors, including family dynamics. So when we talk of illness, the coping mechanisms that a person and his or her family members will develop in relation to that medical condition will define how this patient will cope with that medical condition or that illness. We talk of financial burden of the illness. When a family member contracts, let's say, malignant neoplasm or cancer. For example, when my mom died of metastatic breast cancer, that breast cancer didn't just affect my mom. It also impacted on my dad. It also impacted on all children, even for adult children and even for the grandchildren. That's what we mean by illness. Family members tend to um bring together all their resources to ensure that when there is a fatal or there is a critical condition within the family, that we will be able to cope with that medical condition adequately to meet the health needs or requirements of that person or relative who has been done with a particular medical condition. Now, we now move to the epidemiologic models of diseases. There are several of them: the germ theory, the ecologic triad of communicable diseases, the epidemiologic lever, and the web of causation. We will discuss all of these in detail, but I would highly recommend all of you to do further reading on these topics because it will be impossible for me to really discuss everything in specific details. So let's begin with the germ theory. There was a time when we divided the era of medicine, of modern medicine, into two phases. We first have the miasma phase, and during this period, disease was attributed to bad air and elements. So perhaps centuries ago, when a person would get sick, they would say, "Oh, you are being punished by the bad spirits because you did something bad." And back then, specific causes of disease were unknown during this miasma phase or during this era. But then we started to learn more of the microbiological causes of diseases. During the germ phase, specific pathogens were recognized as the cause of your communicable diseases. And this phase marked a watershed in the concept of disease, and the hunt for pathogens was carried out on a war footing. So, one of the first few experts or scientists or physicians who looked into this particular germ theory is Dr. Louis Pasteur. And he was able to prove that there are medical conditions that were secondary to the presence of your microscopic organisms or different forms of life. The germ theory states that specific microscopic organisms or pathogens are the cause of the specific of certain communicable diseases. This theory was developed, proven, and popularized in Europe as well as in Northern America sometime from 1850 to 1920. It is because of the germ theory that we now know the bacteriological concept of disease causation, which opened up new avenues of disease prevention and control, which would include isolation and quarantine. I am unsure if you still recall 5 years ago when all of us experienced the COVID-19 pandemic. So we were experiencing health protocol by the government that would restrict our movement. So we have the concept of quarantine, which basically keeps someone who was in contact with a person has been infected with a medical condition during the period of communicability, let's say the period of the incubation period. So when you quarantine a person, that person is still well. However, there has been exposure already to a sick individual, and you wait for that incubation period to lapse before we can let this person who was exposed to go about his activities or his or her activities of daily living. In contrast, when we say isolation, isolation would restrict the movement of people who are already sick with the virus or with the bacteriologic organism that is causing the medical condition. So, again, just to simplify things, when we talk of quarantine and isolation, this refers to the rigid uh non you disallow a person or you restrict the movement of the person to ensure that infection will not ensue. So you quarantine people who are well but have been exposed, and you isolate people who are already sick. It also led to the emergence of preventive measures such as the acts of disinfection and fumigation, and it also led to research studies on origins and modes of transmission of certain pathogens and microorganisms. Because of the germ theory, we now know a variety of pathologic microorganisms that can bring about certain communicable, infectious, and tropical diseases. So we have identified thousands of bacterial species, viral pathogens, fungal infections, protozoans, which would include, let's say, your amoeba, your parasites. For example, when we talk of your soil transmitted helminthiasis, or your prions, which are basically proteinaceous viral elements, quite similar to a virus that can cause, let's say, your spongiform encephalopathies, such as your mad cow disease. So there is a difference between a bacterium and a virus. You will learn more of the stark differences of these organisms when you go into microbiology, parasitology, and immunology in sophomore year. But in essence, a virus is an obligate parasite that would require another host cell for it to replicate and assume the central dogma of life. Unlike your bacterial species, which are independent organisms that can thrive even in the absence of your host cell. So that's the main difference between a virus and a bacterium. And again, you will learn more of these when you go to microbiology and parasitology in sophomore year. Now, what are the basic concepts that arose from the ecologic concept of disease? The ecologic concept of disease would look into the interplay of three things. You have your infectious agent, the human host, and of course, the environment in which the interaction of the agent and the host will happen. We do know that disease is the result of the imbalance between the forces of the infectious agent and the host. And the resulting imbalance depends on the nature of the infectious agent, as well as the characteristics of the host, and the nature of the infectious agent and the host as well as their interaction will depend on the environment to which they are present. The result of the interaction of these two forces of the agent and the host, as well as the differences in their relative magnitudes, will determine what will happen to the host's body. So basically, if there is equilibrium, let's say you are in a good state of health, the force of infection and the force of infection of the agent and the force of resistance of the human body host are able to achieve a certain balance, and so you are still okay or you still are healthy. However, in the event that, let's say, the human force of resistance is subdued by the force of infection, then that's the time you will develop the disease. Now, it is also important that we discuss very briefly the spectrum of infection. Now, the relative magnitudes of the force of infection and the force of resistance may vary from time to time, and the results of these relative variations of the forces are reflected in the various stages of infection and disease. Truth be told, this concept is a very, very old concept. Now, the first time this is actually lifted from the book of Dr. Dizon, which was written, I think, circa 1970s. Some of you might feel, oh, it's already outdated, it's already passé. We're already in the year 2025, and is it still relevant? Is it still um applicable? To a certain degree, yes, it is still it is still applicable for academic purposes, and there is a possibility that this still can appear in the physician licensure examination, and therefore I feel it is imperative that we briefly discuss the spectrum of infection, although some epidemiologists might consider this concept relatively to be old. So when we talk of the spectrum of infection, this is also written in your manual. So I will just in your review notes and manuals. So I will just give you the reading assignment to go over these. But what is important is there is an identified carrier stage for some medical conditions, in particular your communicable diseases. When you say there is a carrier stage, it is possible that a person might harbor a particular pathogen in his or her body, but this pathogen is not producing any significant clinical symptomatology. And so he or she is infected, but it doesn't automatically mean he or she is in a disease state because there are no visible signs of the interaction of the agent and the host at this point yet. And so this can eventually involve to what we call now your missed cases or your mild cases, then it can move on to your moderate cases and your severe cases that can ultimately lead to the demise of your patients. So, when we're talking of the spectrum of infection, especially for your communicable diseases, this would already be the end or the last part of the spectrum wherein there is the inevitable death of your of the patient. So we now go to the natural history of disease. The natural history of any medical condition refers to the progress of a disease process in an individual over time in the absence of appropriate intervention. Meaning to say, if you do not give the needed drug of choice, or you do not, or you deliberately withhold the giving of needed therapy, then this is the time that the natural history of the disease will eventually progress. The process begins with the exposure of accumulation of factors capable of causing disease, and without medical intervention, the process would eventually lead to any of the following outcomes. There could be complete recovery, or there could be some form of partial recovery with disability, or ultimately it can lead to the demise or death of your patient. So this is a graphical illustration of the natural history of disease. This is actually the same for most communicable and to a certain point to some non-communicable diseases. But what is important is to identify that there is what we call your pre-pathogenesis and your pathogenesis period. When we talk of the pre-pathogenesis period, this is where the preliminary interaction of the potential infectious agent and the host in a given environment would often take place. And this is the state at which man is not yet involved by the disease process. And during this stage, however, the agent, the host, and the environment interactions will bring together the agent and the host to produce a disease-provoking stimulus in the human host. This eventually leads to the pathogenesis stage. The pathogenesis stage will take place within the host's body, starting with the first interaction with a disease-provoking stimulus that will precipitate changes in form and function of cells, tissues, or organs, which ultimately result in defect, disability, or death. Now, your pathogenesis stage is divided into several parts. You first have your incubation period. During this time, there is no specific manifestations are evident. However, there could already be beginning cellular or tissue reactions happening. This refers to the time duration between the receipt of the infective organism by the susceptible host and the first clinical manifestations of the disease. The incubation period is the most ideal time for us to conduct public health measures such as contact tracing. This is also a very good period for epidemiologists and surveillance systems to monitor progress of the disease. This is where we can provide vaccination that would further halt the progression of your infectious process. We can identify the beginning as well as the end of an epidemic or a disease outbreak. Then you have your clinical period. When you say clinical period, there are already overt signs and symptoms that are being manifested or that are being exhibited by your patient. Symptoms are subjective complaints of the patient. When you say, I feel weak, I am feverish, I have no appetite. These are all symptoms that are subjectively felt by the patient. Signs, on the other hand, are objective findings that the physician can properly quantify and objectively measure. If I get your temperature, and then I say, oh, your temperature is 38.5, you have fever. When I get your blood pressure, oh, your blood pressure is elevated. If I get your blood and there is presence, let's say, of elevated white blood cells, leukocytosis is suggestive of possible infection. If there is neutrophilic predominance in the blood, this is basically what we refer to as potential bacterial infection. If there is lymphocytic predominance, this could be suggestive of your viral infection. So clinical signs and symptoms are now evident during this period. It is further divided into your prodrome, your frank illness, and the chronic stage. Prodrome would include mild, non-specific signs and symptoms. For example, if you have fever, loss of appetite, generalized body weakness, these are all commonly encountered in upper respiratory tract infections, in acute viral infections, in urinary tract infections, even in cancer. So the prodrome are very non-specific constitutional signs and symptoms. When the symptoms are more specific, let's say, for example, you start to develop ictericia, Your sclerae of your eyes become yellowish, you become jaundiced. Jaundice is often suggestive of liver pathology. That's your frank illness. Or if you start, let's say, expectorating blood tinge sputum, that could be suggestive of lung cancer or pulmonary tuberculosis. So that is also a frank illness. Chronic stage is when the complications will set in. Let's say, for example, if you're suffering, let's say, from diabetes, eventually, if there is uncontrolled hyperglycemia, what happens is that your kidneys will eventually be affected by the uncontrolled blood sugar. This is part of the microvascular complications of your diabetes. It causes your diabetic nephropathy. And we do know from basic human physiology that the kidneys, as well as the adrenal glands, are necessary for the production of your hemoglobin. And so when there is faulty or weakened kidneys and adrenal functions. It also affects the hematopoiesis or the production of your red blood cells that eventually lead to anemia or low hemoglobin levels. So, diabetes causing chronic kidney disease, causing secondary anemia, these are all suggestive of the chronic stage of your uncontrolled diabetes mellitus. And then eventually, depending on how well your body is able to um, combat or affect uh, or cope with the infectious agent or a disease process, this can lead to any of the outcomes, recovery, or sometimes, sadly, even death. So, in the natural history of disease, this is where the agent host environment interaction happens. It is often evident and most visible in the pre pathogenesis stage, when there is a stimulus that will precipitate onset of diseases. There is what we call your imaginary clinical horizon, which differentiates your prodromal or your non-specific changes from those of the overt clinical manifestations and signs and symptoms that are being documented already. So from the agent-host interaction, this is where we have the ecologic triad. So before, when we talk of agent, we would often refer to them primarily as the communicable causes. But this has evolved to now involved, it has evolved to include rather your chemical or your physical agents, as well as nutritional factors. Lack or excess of nutritional elements can also be regarded as agents. Then the environment are certain characteristics that would shift the balance of the infectious agent as well as the host. And we will go over these very briefly, one by one, starting with the agent. When we're talking of the etiologic agent, this can refer to any element, substance, or force, whether living or non living, the presence or absence of which can initiate or perpetuate a disease process. Properties of an etiologic agent would look into inherent characteristics, those that are directly related to the host and those related to the environment. When I say inherent characteristics, let's say we talk of the physical features of your bacterial species or that of the viral capsid or the viral capsule. We look into the biologic requirements. Let's say, for example, for the HIV to replicate in the human body, what biological requirements will it require? What will it need? The chemical makeup, the viability, and the resistance are just some of the inherent characteristics that we look into of the etiologic agent. We also look into the morphology, motility, the presence or absence of capsules, or the ability of your etiologic agent to develop dormant forms such as your spores or cysts. For example, when we're talking of morphology, um, there could be the presence of certain structures that would cause this bacterium or this etiologic agent to be more virulent. Presence of micro of your cilia or your flagella could also be a factor in the disease causation. Capsules sometimes protect your bacterial infections from infections. Let's say when we talk of antibiotic therapy, there would be antimicrobial agents that work specifically on the peptidoglycan layer of your bacterial species, or they attacked the capsules, or when there are dormant spores. For example, your Clostridium difficile is a common nosocomial pathogen that can produce diarrhea. Sometimes it can have spores um, that um, that remain resistant to certain antimicrobials. So these are just some of the physical features of your etiologic agents, which can make them difficult to cure or combat. Biologic requirements presents the need for oxygen. There are, for the medical technologists in the group, you do know that there are what we refer to as your aerobic versus your anaerobic bacteria. For example, your Clostridium difficile, as well as other species of your Clostridium botulinum, Clostridium perfringens, they are all considered anaerobic pathogens that would prefer low levels of oxygen for it to thrive. Tropism refers to the agent's preference to attack and stay in special location in the host. For example, your Vibrio cholera is notorious for causing what we call your rice water diarrhea because there is predilection for the Vibrio to stay in the digestive tract. Your Staphylococcus aureus, which is a gram-positive bacterium, is most commonly seen on the skin. Your varicella or your herpes zoster is a viral species that is known to stay dormant in the nervous system. Or your poliomyelitis, which is a bacterium targeted by our vaccination, which tends to affect the anterior horn cells of the spinal cord. We also look into concepts of infectivity, pathogenicity, virulence, and antigenicity. Infectivity refers to the ability to gain access or entry into the human host. Pathogenicity refers to the ability to precipitate specific reactions, whether local or general, whether clinical or subclinical. Virulence, on the other hand, refers to the inherent capacity of your agent to cause death or mortality. While antigenicity refers to the ability of the agent to induce production of antibodies by the human host. Why is this important? If you will recall, at the peak of the COVID-19 pandemic, we've heard of various variants of the COVID-19. There are different characteristics. Let's say, for example, there are differences among the alpha, the beta, the gamma, the delta, and the Omicron variants of your COVID-19. Your Omicron variant was identified to be the one that is easily transmissible. But unlike your alpha, your beta, they did not produce significant, your Omicron does not produce significant mortality or virulence. So it's highly infective, easily transmissible, but compared to other variants, your Omicron doesn't cause much virulence. So just to highlight specific examples where you can see the differences of these variants defining the previous concepts of antigenicity, virulence, so on and so forth. Agents with high infectivity and pathogenicity but low antigenicity will cause a relatively high disease prevalence in the community. When I say prevalence, I am referring to the number of new and old cases at a given period. This is to differentiate it from your incidence. Incidence refers primarily to the number of new cases in a population at risk. So when I say prevalence, I am referring to the number of old and new cases. When I say incidence, I am referring to the number of new cases. So when we say, what's the prevalence of diabetes for 2025? When I say prevalence, I am counting people who have been diagnosed with diabetes before 2025 and until now, 2025. When I say what is the incidence of diabetes, only those who were newly diagnosed to have diabetes in 2025 will be counted. So I hope you know the difference now between your incidence and your prevalence. Agents with high infectivity but low pathogenicity would usually produce milder subclinical symptoms and even the disease carriers. Now, hepatitis A, for example, in children has low pathogenicity and low virulence, since many infected children remain asymptomatic and only very few develop severe illness. In contrast, in persons with good nutrition and health, measles virus has high pathogenicity but low virulence, since almost all infected persons develop the characteristic rash illness, but few develop the life-threatening presentations of your measles, your pneumonia, or your encephalitis. On the other hand, in persons with poorer nutrition and poorer health, measles has been documented to be more virulent with a mortality rate as high as 5 to 10%. And another example will be your rabies. This is highly pathogenic and virulent. In fact, it is considered virtually 100% fatal for all persons who become bitten by a rabid animal and they did not receive the needed post-exposure rabies prophylaxis. So make sure whenever for us doctors, when we encounter animal bite patients, especially bites of animals that are rabies prone, which would include your dogs or cats, your cattle, your horses, we definitely give, or your bats, we definitely give the rabies post-exposure prophylaxis the soonest possible time, warranting the giving of both your immunoglobulin and or your rabies vaccine and or your rabies immunoglobulin on top of the tetanus prophylaxis. We also talk about the modes of transmission, your reservoir, and your source of infection. We can divide the transmission of infectious agents into two. You can dichotomize them as your direct transmission and your indirect transmission. When you go to parasitology, you will learn more of these. When I say direct transmission, there is direct physical contact or via droplet spread. When I say it's indirect, we can use your vehicles, your fomites, for example, mga dirty clothing or mga hiwa ka ng rusty, you are cut by a rusty knife. Your tetanus can be transmitted by that vehicle. Or when I say vector-borne, vector-bornes are either mechanical or biological vectors. This would involve usually insects, no? Airborne or your aerosol. You might ask me, what's the difference between your droplet spread and your droplet nuclei airborne transmission? Droplet spread would often involve bigger particles. That is why when you cough it out, The droplets are very big, and so they automatically fall to the ground because of the pull of gravity. Because they are bigger particles, they can only move into certain distances. If you will recall, during the COVID-19 pandemic, your COVID was first believed to be spread via droplet route. That is why we did the physical distancing. If you are more than 6 feet away from the person, a droplet spread transmission will become unlikely because of the short distance that the big molecules will travel. On the other hand, when I say airborne, these would involve your droplet nuclei. So there is a difference between your droplet spread and your droplet nuclei. Droplet nuclei are very small particles that remain suspended in the air. So, for example, I have tuberculosis. I cough. When I cough, I didn't cover my mouth. The airborne particle or the droplet nuclei will remain suspended in the air. I leave the room. Then a second person enters the room. Even though the person with TB has already left the room, the mere fact that the droplet nuclei remain suspended in the air makes it possible for the person who entered the room to still acquire the infection, even if there is no direct interaction with the person previously infected with tuberculosis. So that's the difference between your airborne droplet nuclei versus your direct droplet spread. It differs by the size of the particles and the ability to remain suspended in the air. Now, a reservoir would refer to the usual habitat in which an infectious agent would normally live, grow, and multiply. The reservoir may or may not be the source form from which an agent is transferred to the host. Reservoirs could be humans, for example. This is a classical picture of your variola or your smallpox. Your smallpox has been eradicated already. When I say eradicated, there is zero incidence and there are no active interventions being undertaken to maintain and sustain that zero incidence. Your variola is believed to be eradicated because we no longer require the vaccination against smallpox, and all of us are no longer seeing variola or smallpox in the human populations because the human reservoir has been protected by herd immunity from our ancestors decades ago. Then you could have your animals as your reservoir. This is an example of your anthrax. Your anthrax is a bacterium that normally thrives in cattle or in cows. So when there is interaction with an infected cow, you can get your anthrax, no? Unfortunately, both your variola or your smallpox as well as your anthrax, these are believed to be considered organisms being used for bioterrorism, no? Because of its fatal ability to cause fatal outcomes in patients. Then you have your environment as a reservoir. For example, this is your Legionella pneumophila. This bacterium has been noted to thrive in damp environment. The first documentation of the Legionella pneumophila led to what we now refer to as the Legionnaire's disease. The Legionnaire's disease happened when a group of businessmen convened, and what they didn't know was in the air conditioning units of the convention hall, the bacterium Legionella pneumophila was present in the air filters of the aircon. And so when that air conditioning unit was turned on, most of the participants in the said conference contracted this severe lung infection, which we refer to now as your Legionnaire's disease. So we also talk about carriers. Again, a carrier is an individual who does not possess apparent overt clinical manifestations, but nonetheless, that person has the ability to transmit the agent to other individuals. There could be what we refer to as your asymptomatic passive carriers. A perfect example will be your typhoid. I want you to read on Typhoid Mary. Typhoid Mary is a cook who unfortunately didn't wash her hands every time she would prepare food. And what happened is that she was able to transmit your Salmonella typhi from one person to another because of the food that they were consuming, which Typhoid Mary prepared. Sorry for that. Which Typhoid Mary prepared, and she um she unknowingly transferred the salmonella to other individuals. Then you have your precocious carriers. When you say precocious carriers, these may often have latent incubation periods. For example, your HIV. If you get your HIV testing done now and you yielded a negative result, and yet you engaged in high risk sexual activity, make sure you have your HIV test rechecked after 6 months, because it's possible that you only had yourself tested during the window period wherein there is still inability to detect the virus inside of you, but you may already harbor it, pero hindi lang siya na-detect easily. That's your precocious or your incubatory carrier. Your convalescent carrier is the one wherein you become more effective during the period of recovery. So, for example, those with chickenpox or your varicella. If you are familiar with varicella, eventually your vesicles become umbilicated ulcers, or in umbilicated lesions of the skin. When the vesicles rupture, you see a glistening area of the umbilicated lesion that is actually more infectious compared to having those vesicles. So that period of recovery wherein you have umbilicated lesions are more infectious compared to those that you have your scab formation or your vesicles. And lastly, you have your chronic carrier. The most popular will be your hepatitis B virus. Your hepatitis B is notorious for causing fibrosis and eventually cirrhosis and hepatocellular carcinoma in humans. That is why your HBV is the first vaccine preventable cancer. We vaccinate all children 3 doses. And immediately at birth, you give the first dose already of your HBV vaccine, because we don't want our children to develop chronic carrier states of your HBV or your hepatitis B. So I mentioned this, you have your animal reservoir. Your animal reservoir are called there can transmit conditions that we refer to as your zoonosis. Examples of which will be your rabies, your leptospirosis that can transmit your Leptospira interrogans from infected urine of rodents, or your Creutzfeldt-Jakob disease, which is one of your prion related spongiform encephalopathies. No? This is very similar to your mad cow disease or your kuru. Your kuru is a human type of spongiform encephalopathy that causes CNS or central nervous system manifestations because of cannibalism in a tribe in Papua New Guinea. That is your Kuru. It's very similar to your Creutzfeldt-Jakob disease, one of your prion-related encephalopathy, spongiform encephalopathies. Creutzfeldt-Jakob disease is often associated as the mad cow disease. Then I've mentioned this, the environmental reservoir. I've mentioned about Legionella, Pneumophila, or sometimes even your histoplasma. Histoplasma is often seen in in bat excreta. If you are a spelunker or a cave explorer, and you get to be exposed to dung or to the excreta of your bats, inside caves, the bats can contain this fungus, your histoplasma, that can also cause skin manifestations. We now move to your host. Now, in the host, there are many characteristics that can precipitate disease and illness. Host factors would include age, your sexual orientation, gender identity and expression, race, culture. While your host defense mechanisms would look into your anatomical susceptibility, immunity, inherent susceptibility, resistance, and tolerance. What are the factors associated with disease causation? We have your predisposing factors, you have your enabling factors, your precipitating factors, and you have your reinforcing factors. And we will go over these one by one. Let's talk about age. There are certain medical conditions which are more commonly encountered in certain age groups. For example, when we're talking of the pediatric populations, age will definitely define certain common pediatric infections, such as your whooping cough or your uh, uh, it would include your pertussis, your uh pseudomembrane infections. So this is an example. You're from your Corynebacterium diphtheriae, where there could be pseudomembrane formation in the tonsillar areas. If you accidentally puncture this pseudomembrane that you see in the throat, it will release the toxins and it could lead to the demise of a pediatric patient. That is why when we're talking of your vaccine preventable diseases under the expanded program on immunization, our target would be children because they are the ones that are susceptible to developing certain medical conditions. Still related with age is this one. When we're talking of sexually transmitted infections, when you see males or females that present with um, foul smelling, copious yellowish green discharge in the penis or in the in the vaginal area, you think automatically of sexually transmitted infections such as your gonococcal urethritis. Although we know that this is more commonly seen in patients in the younger age groups. When I say younger adult age groups, it would be patients in their 20s, second or third decades of life. This is a factor of age because during this period, you are more sexually active. And so when you get contract sexually transmitted infections, it is common because of your age group. However, if you see this in a 12-year-old child, the context of the infection is different. You might not think of consensual sex, but you think of possible assault, sexual violence, rape, because you don't normally see sexually transmitted infections happening in younger children. Again, how age could be a factor that can predispose one to certain medical conditions. When we're talking of mid lifestyle disorders, when we're talking of, let's say, coronary artery disease or ischemic heart disease or cerebrovascular accidents. Your heart attack and your brain attack, they produce the same pathology. There could be impedance with the blood flow, or there could be rupture of blood vessels that can cause these symptoms. You don't normally see this in people of your age group. This is more common in seen in older age groups. Let's say, for example, persons on their fifth, sixth, seventh decades of life. Again, a factor of age. When we're talking of Down syndrome has a predilection to be more common in women who develop their first pregnancy beyond 35 years of age. We refer to women who become first pregnant to be greater than age 35 years old to be elderly preemies. When I say elderly preemies or elderly primigravida, they are at a higher risk of having children with Down syndrome. So this is another factor for age. I'm not sure if you know this picture. These pictures were actually part of the campaign of the World Health Organization in Europe during the early 2010s, when Adam Levine was at the top of his career, and he was considered as an icon in the music industry. And of course, he was very physically attractive. So many women were enamored with his physical looks. But in Europe, to increase awareness for testicular cancer, they invited Adam Levine to pose for the campaign of the World Health Organization to increase awareness on doing regular testicular examination as a campaign to increase awareness for testicular cancer. Testicular cancer is one of those diseases with a sorry, with a bimodal peak of incidence, meaning to say testicular cancer peaks during the adolescent period, perhaps 12 to 15 years of age, then a second peak would happen from ages 30 to 40. So there is a bimodal peak of incidence when it comes to age groups for your testicular cancer. We also talk of your sexual orientation, gender identity, and expression. We used to say that lung cancer is more commonly seen in males because males are the ones who are often heavy cigarette smokers. But so that's why we associate lung cancer, your bronchogenic carcinoma, with the male sex because of the habit of smoking or even to occupational hazards. On the other hand, when we're talking of thyroid pathology, your Graves' disease, this is more commonly seen among women compared to men. And of course, your thyroid pathology, your hyperthyroidism can cause your thyrotoxic heart disease. Now, we also look into the MSM, or the men who have sex with other men. When I was in medical school and we're talking of viral hepatitis, there were six more commonly encountered viral hepatitis: hepatitis A, B, C, D, E, and G. Among the six, the most popular or the most common would be the five: A, B, C, D, and E. Of the five, it's your hepatitis A and your hepatitis E, which would be considered to be transmitted via the fecal-oral route. When I say fecal-oral route, this is often like your salmonella, transmitted by excreted in the fecal material, and if you accidentally ingest it, you get infected. So fecal-oral ang A and E, and then B, C, and D usually through the exchange of bodily fluids, sexual intercourse, blood transfusion, vertical transmission from a pregnant mother to the growing fetus. So when I was in medical school, hepatitis A and E were considered fecal-oral route, hepatitis B, C, and D were considered through exchange of bodily fluids. However, when I was after residency in PGH, we learned that your hepatitis A has been reclassified to be also considered sexually transmitted also among the MSM. So MSM perform the acts of fellatio and sodomy. So when they engage in oral sex or fellatio, and they engage in receptive or insertive anal sex or sodomy, it actually completes the cycle of the fecal-oral route of transmission. That is why your hepatitis A among the MSM is now considered sexually transmitted as well. Again, a factor of sex. We also look into the socioeconomic status. Why? Sometimes, if you reside in poorer communities, you can be at the higher risk for developing what we refer to as your neglected tropical diseases or your NTDs. NTDs are considered neglected because, first, there is very few research studies being conducted for these NTDs. Why? Because NTDs are more common in tropical poor countries. Those that fund research are usually from the temperate regions. For example, when the US left the WHO, funding for studies for lymphatic filariasis, schistosomiasis, rabies, leprosy, and your soil-transmitted helminthiasis, they were all suspended. They were all suspended, and so there is a form of neglect because not much epidemiological research can be conducted without proper funding. It is also neglected because often people affected or inflicted by these NTDs are the ones living below poverty line, and so they have no access to medicine that would be considered imperative to combat these infectious diseases. So socioeconomic status impacting on your neglected tropical diseases is also an example of how the living environment can precipitate certain conditions. So again, we are trying to combat NTDs. This is the Global World Health Organization roadmap to combat and address the public health burden of your NTDs. Housing and environment can also be very important in terms of disease causation. In the 1960s, there was this um, theory, the Mills-Rinke phenomenon, which said that if you just provide adequate supplies of potable water, you can actually lessen the burden of both your communicable as well as your non-communicable diseases. So looking into this Mills-Rinke phenomenon, we do know that it is imperative that we are also being able to provide access to clean, potable water on top of the sanitation of the environment. So when we talk of water sanitation and hygiene, the World Health Organization divides your waterborne diseases into four parts or four categories. You have your waterborne diseases, your water wash, your water-based, and your water-related diseases. When I say waterborne, usually you get the infection through drinking contaminated water. Water wash is because of lack of proper sanitation and hygiene. When you say water-based, normally there is an aquatic invertebrate organism that transmit it. And when we say water related, they're often your vector borne or your insect borne infections. Kaya nga, di ba, we have communities where there is no access to clean water. No, some of the political dynasties use this to develop learned helplessness in some of our countrymen. No? That's why it's very, very controversial now. Why there are certain political dynasties that are being questioned as to why their family continues to restrict access to clean potable water. So just to for a break run through, when we're talking of these conditions, so waterborne diseases would include your amoebiasis, water wash would be your ascariasis. Then you have for your water-based your schistosomiasis, and water-related diseases your dengue. Then we go to your occupational safety hazards. So when we talk of the working conditions or working environment of employees, they can also be related to certain diseases. And this is where the importance of occupational safety and health becomes very relevant. So when we're talking of OSH, we can divide them into your hazards, and we have your electrical hazards and your fire hazards. But we also have your health hazards. So we divide your hazards into your physical, your chemical, your biological, your ergonomic, and your psychosocial hazards. Under your physical hazards, this would include noise, illumination, temperature, pressure, vibration, and radiation. When we're talking of noise, there is established threshold levels where certain amount of noise can be considered acceptable. Beyond the threshold, it becomes detrimental to one's health. Any exposure to chronic loud noise of more than 120 decibels is something that we want to avoid. If you are exposed to 85 to 90 decibels of noise, it can lead to permanent hearing loss throughout your working lifetime. And when we talk of occupational induced noise hearing loss, you can also have your acoustic traumatic injury, which is sensory neural, or you can have your noise induced hearing loss, which can also be considered neurosensory in origin. So, for example, if you are working in an environment where you use a rivet hammer, or you are employed by PAL or Cebu Pacific, and you work with the airplane propellers, if you use your rock drill, or you are um you are working in a steel metal shop, the amount of noise that you are exposed to are the following. Based on OSH standards, if you are exposed to certain loud noise, there is a maximum duration for you to be exposed to these types of noise. Anything beyond that threshold is considered ill to you, or it's already considered harmful or injurious to your health. Same thing for illumination. There are certain requirements that a certain light level measured in lux will be considered permissible. For example, for us working in a first aid station, the light illumination should have at least 500 lux. If the lighting is lower than 500 lux, it's not ideal for the healthcare workers in that assigned first aid station. Because of poor illumination, this can lead to certain eye conditions, including your visual fatigue, vascular headache. It can cause painful irritation and lacrimation, and even conjunctivitis. Another physical hazard will be extremes of temperature. If you are exposed to either very cold or very warm work environment, it also affects the way you engage or the way you are working or functioning. So there are also threshold levels for such. Or if you are working in extremes of pressure, for example, our Muruami fishermen, when the Muruami children dive in the bottoms of the ocean to look for fish or shellfish, they are not properly equipped with the needed um, swimming gear. And so many of them develop perforated tympanic membrane because of the sheer force of the pressure below sea level. And that is something that is also very harmful. But again, they are considered um, one of the, sadly, no, our children who are forced to go into child labor, in particular the Muruami fishermen in the south. When you are exposed to severe vibration, it can cause also, even sadly, no, viscous rupture, or there could be hand-arm vibration syndrome, and it can also precipitate certain medical conditions. So just to show you some of the more commonly encountered hand-arm vibration syndrome associated with vibration. Radiation. This is also something that is quite relevant. You have your ionizing and your non-ionizing radiation. For example, in the medical field, if you are working as a radiologist or a rad tech or a radiology technician, you are exposed to radiation. That is why we monitor your level of exposure to such radiation types. Some of the more commonly encountered radiation-induced medical conditions are as follows. Look at this. Even sterility, having children with birth defects, could be associated to chronic exposure to harmful radiation. For the biological hazards, this could include your microbes, your parasites, your arthropods, reptiles, birds, and other rodents and other mammalian species. When you are exposed to possible biological hazards, there should be proper testing of certain living material. For example, we can check for your urine analysis. We check for your fecal material or your fecalysis. We check other bodily fluids for possible exposure to biological hazards. For the chemical hazards, there are 400 million tons of chemicals produced yearly. And with proper handling, even highly toxic chemicals can be considered safe. However, there could be possibility of contamination or exposure to such harmful chemicals. And from an occupational medicine perspective, it is imperative that the workplace should also provide always MSDS or material safety data sheet in the event that there would be exposure to such hazardous materials. We also talk of your threshold limit values, which refer to the maximum levels of exposure to certain chemicals before we consider them to be considered harmful. Just to show you examples of certain chemicals that we encounter in the workplace and their potential TLVs or threshold limit values. Then we go to your ergonomics. Ergonomics would look into hazards when the type of work, body position, and working conditions can potentially put strain on the human body. If there would be, let's say, forceful exertion, awkward static postures, if you are required to do repetitive motions, or your workstation is not designed properly, this can precipitate various occupational health conditions, such as your work related musculoskeletal disorders or your chronic lumbago, your repetitive strain injuries such as your carpal tunnel syndrome or your cumulative trauma disorder. Let's say, for example, you are a CAD artist and you are working in your workstation. In your workstation, sometimes you can be, let's say, working with a mouse, and there is repetitive movement of your hand, of your wrist. It can impinge on the median nerve, causing your carpal tunnel syndrome. The last will be your psychosocial occupational hazard. Any factor that affects the mental well-being or mental health of the worker by overwhelming individual coping mechanisms and impacting the worker's ability to work in a healthy and safe environment. These are all considered psychosocial health uh, conditions. No? So, for example, if there's workplace violence and harassment, if you're forced to work alone, if there's a technological change rather, or fatigue and work hours. So the DSM 5, this basically used for mental health disorders. They have already identified what we refer to as your occupational stress syndrome. So also, if there's repeated exposure, there could be digital eye strain, or sometimes, remember, at the peak of the COVID-19 pandemic, we were having a little bit of Zoom fatigue because of the numerous online meetings that we were having. Then the last is we go into the environment. When we're talking of the environment, these would include climate, geography, biologic environment, and socioeconomic factors. We do know now that climate change has can affect the human population significantly. I want you to do further reading on this because it will be impossible for me to give a rundown on all of these, but I just want you to identify that there are certain conditions that have been associated with climate change. When we talk of medical geography, this is an area of medical research that incorporates geographic techniques into the study of health around the world and the spread of diseases. In addition, medical geography studies the impact of climate and location of individuals' health, as well as the distribution of health services. Medical geography is an important field because it aims to provide an understanding of health problems and to improve the health of people worldwide based on the various geographic factors influencing them. A more popular example will be, how did dengue emerge in human populations? It was believed that dengue originally started what we refer to as the sylvatic dengue, more commonly seen in the primates. And this was seen in the jungles. It was transmitted by several species of the Aedes genus of mosquito, and it was first seen basically in the primate population. Now your dengue, your this is your rural dengue. Now what happened was your dengue also had the ability, the mosquito had the ability for your trans ovarian transmission. And so what happened was, when people started to inhabit when people inhabited the forests, there was now exchange or exposure from the sylvatic to the rural dengue involving humans. And when the humans went back to the urban areas, it now led to what we now refer to as your urban dengue or urban community dengue. When I did my master's of science in tropical medicine in 2013 and 2015, and part of my curriculum was that I did a bit of mosquito work. I dissected mosquitoes at the viral laboratory in Bangkok, In particular, at the Mahidol University Armed Forces Research Institute for Medical Sciences, or AFRIMS. And I remember in Thailand that the more common type of dengue was the rural dengue transmitted by the Aedes albopictus. In Manila, the more dominant dengue would be your urban dengue transmitted by your Aedes aegypti. And I was surprised that there was a difference with the epidemiology of dengue in Bangkok versus Manila, considering the fact that we are both Southeast Asian nation within the same more or less area in the globe. And so what was surprising is that for them, their dengue was more common in the rural areas rather than in the urban areas, unlike here in Manila, which is more common for the urban dengue. Medical geography. Then we go to the social determinants of health. These are the non-medical factors that influence health outcomes. These are conditions in which people are born, grow, work, live, and age, and it includes it includes a wider set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development agendas, social norms, social policies, and political systems. The social determinants of health have an important influence on health inequities. When I say inequities, this would refer to the unfair and avoidable differences in health status seen within and between countries. The sad reality is, in countries at all levels of income, health and illness follow a social gradient, meaning to say, the lower the socioeconomic position, the poorer the condition of health of that people. I always believe that, and I opine that health is always political in nature. And if you look at the social determinants of health, the World Health Organization divided them into what we refer to as your structural determinants and your intermediary determinants. Under your structural determinants, look at leadership and governance. That is why I always tell students, you have to be political when we're talking of health, because leadership and governance, together with public policies, macroeconomic policies, social policies, would dictate on how it would impact on health inequities. This is on top of the psychosocial variables that affect the health system as intermediary determinants of health. We now move into the epidemiologic level, something similar to the ecologic triad. Basically, what this tells us is that if we are at an equilibrium wherein there is a balance between the forces of the agent and the forces of the host, then we are in the pink of health. However, sometimes there are ways that the agent becomes more pathogenic, and so it becomes more powerful than the host, and so it causes illness. But there are times where we increase the resistance of the host that confers protection against the agent. Sometimes there is no change in the inherent characteristics of either the agent or the host, but there is a shift in the environment that would favor sometimes the host, or sometimes it would favor the agent. So this is basically just the concept of the epidemiologic lever. Then the web of causation would tell us that for all conditions, whether we're talking of communicable or your non-communicable diseases, we can look into a myriad of variables that cause the interplay, and their interplay would result in the outcome or the creation of certain medical conditions. So just to share with you some of the more commonly accepted webs of causation for cardiovascular diseases and diabetes mellitus. The chain of infection would basically also look into all of these. We just relate how the agent would successfully enter the host, how the agent would leave the host and to infect or another person. These are the links to the chain of infection. And if we are to come up with public health strategies to prevent transmission, we break the links of the chain of infection. We also go briefly into the time elements of infection. The starting point is the moment when the pathogen enters the host. This period is often referred to as the exposure moment. Immediately after this, the pathogen usually will move to the preferred tissue or target organ, producing the symptoms that are pathognomonic of the infection. Then the pathogen will multiply, the host system will precipitate an immune response. There will be cellular humoral host defenses that will be activated, and that's the time we develop clinical symptoms, and that's the time we do the diagnostic workup until we are able to diagnose the infection. So just to highlight some of the important concepts when we're talking of latent period of infection, until you become infected, until you develop the overt clinical manifestation. And the period of this would be what we refer to as the generation time. Then we move to the next and last concept, the second to the last concept for today's lecture, which would be levels of prevention. Prevention, therefore, at any given level of application in the progressive natural history disease would depend on the causes related to the agent, the host, and environmental factors, and the ease with which the causes may be intercepted or counteracted are taken into consideration. Prevention requires the construction and interposition of various kinds of barriers in the interaction of these elements, and the degree of success in prevention depends on the completeness of knowledge regarding the natural history of the disease, the opportunity to apply the knowledge in actual application of it. So classically, we have your primary, secondary, and tertiary levels of prevention. However, newer textbooks in epidemiology and public health now identify two new stages, your primordial and your quaternary. So when we say primary prevention, we primarily look into health promotion and the conferring of specific protection either through vaccination, immunization, or chemoprophylaxis. When we talk of early diagnosis and prompt treatment, that would be your secondary prevention. When we talk of your tertiary prevention, we look into disability limitation as well as rehabilitation. I'd like to be quick in saying, though, that disability limitation in other standard textbooks may be categorized as secondary prevention. However, for purposes of academic uh, discussion in UERM, when we say disability limitation, we often place it under tertiary level of prevention. Your primary prevention is often administered during the pre-pathogenesis stage, while your secondary and your tertiary levels of prevention are usually employed during the pathogenesis stage. Now, what is primordial then and what is quaternary? The primordial prevention is very similar in concept with your primary level of prevention. Basically, it avoids the emergence and establishment of the social, economic, and cultural patterns of living that are known to contribute to an elevated risk of disease. For example, whenever I talk of primary and primordial prevention, they would look into the same strategies. We can talk about health promotion, we can confer specific protection. The main difference is that for primordial prevention, there are no established risk factors yet. But for primary prevention, the risk factors are already there. I'll give a specific example. If I give a public health lecture and I discuss the ill effects of smoking, if I talk to a group of grade 5 students, my assumption is they are not yet smokers. So there is no risk factors yet. There are no risk factors yet. So that discussion, that public health lecture on the ill effects of cigarette smoking for a group of grade 5 students can be classified as primordial prevention. But if I deliver the same lecture and my audience will be college students are now old enough to smoke. It's possible that some of the members of the audience are already smokers. So that becomes primary prevention. Primary prevention prevents onset of disease. Primordial prevention prevents onset of risk factors for a certain disease. Same thing. If I give, let's say, your human papilloma virus to a 10-year-old girl for the prevention of cervical cancer, I am of the assumption a 10-year-old girl is not yet sexually active. That's primordial prevention. But if I give the human papilloma virus to a 25-year-old lady who is already sexually active and yet no signs yet for cervical cancer, that's primary prevention. So there is a very thin line that differentiates your primordial versus your primary prevention. When we talk of health legislation, when we talk of Clean Air Act, bawal manigarilyo sa public places. If that is for school children, that's primordial. If it's for college students, it's primary. So there's a very thin line that differentiates your primordial from your primary prevention. So we've mentioned this primary prevention. We look into specific protection, health promotion. I'll leave this as additional reading materials for you. Vaccination, specific protection, just other ways to confer specific protection. Now, when we segregate sick and exposed individuals, when we talk of vector control, environmental sanitation, these are all examples of primary prevention. So we mentioned this earlier on, and ways to control infection. Let's say, for example, for dengue, vector and vermin control, perhaps, or environmental sanitation. Immunization. So there is another lecture for immunization. I will reserve this topic for the other faculty. You can also give chemoprophylaxis. Chemoprophylaxis, let's say, against leptospirosis or against meningococcemia, against malaria, just to give examples on how we increase host resistance via chemoprophylaxis. Secondary prevention, once you try to do screening, any form of early diagnosis and prompt treatment, this would include your secondary level of prevention. When you do periodic health examination in the workplace, annual physical exam, pre-employment physical exam. When you do screening for possible tuberculosis, when you do active surveillance in your local health centers, you can do your sputum smear microscopy, you can do your chest radiograph, You can do your gin experts, and you give free anti-cox medications. Screening also, when you do HIV testing in the social hygiene clinic, or at the peak of the COVID-19 pandemic, we did COVID-19 contact tracing. Tertiary prevention would look into rehabilitation and disability limitation. So, disability limitation can include psychosocial counseling for those that are referred to hospice in palliative medicine, end of life care. This is something that is very important. Rehabilitation, it can include physical therapy, occupational therapy, speech therapy, cardiac, stroke, or burn rehabilitation. Even for patients with autism, for the patient and for the family of patients with children belonging to the spectrum, they engage a lot of rehabilitation services, PT, OT, ST for children with autism. Quaternary prevention would look into avoiding overdiagnosis and overtreatment. There is a concept of antimicrobial stewardship. We do not give antibiotics for viral infections because we don't want to develop resistance. So when you are prudent in giving your antimicrobial agents judiciously, that is part of your quaternary prevention. We do not want to overdiagnose patients, or we do not want overtreatment. I remember when I was a clinical clerk, so we were at Quirino Memorial Medical Center. One of my fellow clerks from another medical school, he was being very playful, but yet, of course, he was reprimanded severely by our seniors. So there was a woman who was complaining of headache. And the female patient, was a bit in her early 30s, and she was a bit good looking. And I remember that co-clerk wanted to perform an internal examination. When you say internal examination of the genital area, you would literally insert your two digits into the vaginal canal to check for, the cervix and all of those things. And his contention was there could be possible catamenial headache, which is basically headache precipitated by the menstrual cycle. I remember vividly that he has a point that when you're talking of catamenial headaches can be related to bleeding, uterine bleeding. But in my opinion, that was an overkill. It was overstretching what you wanted to do just to perform an internal examination. So that's overdiagnosing someone that is not really necessary. Of course, he can be justified that if you want to really rule out any abnormal uterine bleeding that can precipitate catamenial headache. But for me, that was really a stretch just to perform internal examination. So just to cite examples of overdiagnosis and overtreatment. Then the last concept we talk about, the triple burden of disease. We first heard of the triple burden of disease during the term of then Secretary of the Department of Health, Dr. Jean Pauline Obiao. And Dr. Obiao said that there was a shift from the double burden to the triple burden of disease. When you say triple burden of disease, there is an increase in the number of your communicable and your non-communicable diseases, as well as diseases of rapid urbanization and industrialization. This is quite evident nowadays, and addressing the triple burden of disease requires improvements in the health systems, such as efficient service delivery network, functional and strategically located health facilities, and adequate human resource complemented by equitable health coverage policies that ensure access to health care. I want to link the triple burden of disease to the Republic Act 11223 or the Universal Healthcare Law that looks into the life course approach to health across life stages. If there is a clinical discipline that would really champion the life course approach, doctors who cater to the health needs of people from womb to tomb, then that is the specialty field of family and community medicine. We look into the different life stages and we want to address all the triple burden, looking into communicable, non communicable, and diseases of rapid urbanization across the spectrum of age groups. When we're talking of the triple burden, the WHO and the Philippine Department of Health will prioritize the following: HIV and AIDS, tuberculosis, malaria, diseases that are targeted for elimination, your dengue, your leptospirosis, your Ebola, and your Zika infection. I hope you know the difference between elimination and eradication. When we talk of elimination and eradication, we both want zero incidence of the disease. The difference is that for your elimination, you are performing active interventions to maintain and sustain that zero incidence. When you say eradication, there are no active measures already being undertaken to maintain and sustain the zero incidence. For example, if you want to maintain measles elimination rate, then we need to vaccinate our children with measles and MMR as part of the expanded program on immunization. But when we're talking of eradicated variola or smallpox, hindi na tayo nagbabakuna. We no longer give the vaccine because it has been eradicated already. So I hope you know what is elimination and what is eradication. Both will have zero incidence. Elimination, there are active interventions being undertaken to maintain and sustain the zero incidence, but for eradication, there are no active interventions anymore to maintain and sustain the zero incidence. After your non communicable diseases, you have your non communicable diseases. Priority conditions would include your malignant neoplasms, diabetes mellitus, cardiovascular diseases, and your malnutrition. The first three are all related to obesity, smoking, unhealthy diet, and your sedentary lifestyle. Then the last prong of the triple burden of disease would be the diseases of rapid urbanization and industrialization. This would include injuries, substance use and abuse. When I say injuries, it would include victims of physical assault, mauling, vehicular accidents, crash injuries, mental illnesses, pandemic, and travel medicine, and the consequences of climate change. So, what have we discussed for this session? We have gone through the different concepts of health and disease. We look into the natural history of disease. We look into the levels of prevention. This is the natural history of disease superimposed with the different levels of prevention. And again, just to summarize some of the things that we conduct to address health and disease, these are the various levels of prevention. We've also talked about the life course approach and the triple burden of disease. I will not discuss them anything in further detail because you will get to know them more when you go to higher medicine in the next few years. for this session, these are some of the references that I have used in relation to our lecture for this morning. Okay, so with that, thank you very much, and I hope to see you in school one of these days. I wish you the very best, and once again, welcome to the UERM College of Medicine.